Excellent. Welcome, everyone. Thank you so much for joining us. We'll take a second here to let everyone get in. Everyone's kind of rolling in on this hopefully nice spring day wherever you are. And it's been a while since I was with you guys. I'm going to also go over while everyone's kind of rolling in and turn off my email so you don't have to hear all of my notifications the entire time. That's no fun. Okay, so let's go ahead and get started. Hello, everyone. Thank you so much for joining us today for the 7th installment of LBDA's 2024 webinar series, Empowerment Through Education. I'm Julia Wood, the Director of Professional and Community Education here at the Lewy Body Dementia Association, and it is my pleasure to be here with you to host this webinar today. So we are going to discuss how you can best understand and advocate for your rights to physical, occupational, and speech therapy services. This topic is in response to the many LBDA community members who report to us that they have been refused potentially beneficial therapy services, even when they've been referred by their doctor. And I think, as you guys might remember, by clinical training, I'm an occupational therapist. And so, as you can imagine, this gets me a little bit fired up. So before we get started, a few words about LBDA. We are a national nonprofit organization whose mission is to optimize the quality of life, a lot of why you're here today, for those affected with Lewy body dementia. We do this by accelerating awareness, advancing research for early diagnosis and improved care, and by providing comprehensive education and compassionate support. A few housekeeping items for today. You can select the Show Captions button from the bottom of the screen at any time during the presentation to launch closed captioning. You are welcome to submit your questions during this presentation using the Q&A button on the bottom of the Zoom window. Following the presentation, the presenter and I will address a few questions from the Q&A for about 15 minutes. This presentation is being recorded. We get that question often, and an email will be sent out to you if you registered with the link to view the recording in about 1 week. To watch recordings of any of the webinars you may have missed, or perhaps you want to rewatch them, you can visit our YouTube channel at LBDA TV, and Rose has dropped that link in the chat for you. Lastly, when you leave the webinar today, a brief survey will appear asking for your feedback about today's presentation. Please take a moment to complete this survey to help inform our content in the future. All right, so now we're going to learn a little bit more about who's joining us in the audience today. So Rose is going to launch a polling question. And so you'll notice we're asking you if you are a person with Lewy body dementia, if you're a care partner, a friend or family member, healthcare provider, a researcher, or maybe you fall into a category that we didn't think of. Excellent. It looks like, as usual, our care partners are in the lead. But we've definitely got some friends and family members. We've still got those responses coming in, so thank you. We'll give that just a second more. Excellent. All right. And so it looks like the majority, or about half of you, 55%, are a care partner for someone with Lewy. We've got about 12% of our audience are people with LBD. We've got almost 20% of our audience are friends or family members. And then we have some healthcare providers. Thank you for joining us. And then also some others. All right. So we'll take that down now. Oh, and share results so you can see them in case you couldn't. Okay. So now I'd like to introduce today's presenter. And this woman is near and dear to me. She's a great member of my community here in the Philadelphia area. I've known and worked with her and consider her a dear friend and colleague for some time. So Dr. Jennifer Brown is a board-certified clinical specialist in geriatrics with a strong commitment to Parkinson's disease and related conditions. And this is influenced by her personal experiences with her own family members. She earned her master's degree in physical therapy from Springfield College in 1996 and her doctorate from Temple University in 2009. Dr. Brown's pursuit of expertise led her to achieve geriatric clinical specialist certification. And that's a type of specialty certification, you guys, that physical therapists can get. And that's a great certification to look for if you're trying to find a good PT. And she also served as an adjunct professor at Drexel University for their DPT neurological courses and labs for over 8 years. In 2011, Dr. Brown founded Dynamic Home Therapy and serves as the CEO of this private practice specializing in neurorehabilitation services in the greater Philadelphia region. Please use your reaction button at the bottom of your screen to give a warm welcome to Dr. Jennifer Brown. Hi, Jennifer.
Hello, thank you. Oh, you're so cute with all the reactions. I love it.
Thanks for
Julia.
joining us.
Sure. Hi, everyone. And I'm really excited to be here. Very much just like Julie, I'm very passionate about this topic. And we see a lot of clients with Lewy and hear a lot of the same things that Julia was talking about with your frustrations and your experiences in the past or possibly currently with therapy. So, I'm really, really excited to share this with you guys. And hopefully you guys leave with a little bit better knowledge and confidence to advocate for yourselves. So is there anything else, Julie, or I can move forward with starting to share my screen?
You can go ahead and share your screen and I'll exit stage right and join you at the end for questions.
Great. Okay, so just give me a minute, everyone, while I get this going here. All right, and just let me set up so that you'll be able to hear the volume when I show some of my videos. Okay. Hopefully everyone can see the screen here. Here we go. Okay, so today's topic, like I said, is really near and dear. And I talk about this a lot with our community and with other clinicians and just people in the area about understanding and advocating for your rights to rehab in general. And today we will specifically talk about how to do that when there is a diagnosis of Lewy body. So very excited about this. And I'm not going to read all of the objectives, but, I really want you to walk away with knowing how PT, which is physical therapy, occupational therapy, which I will refer to as OT, and then speech language pathology services, which we consider speech, can benefit and give you better quality of life, letting you know what your rights are, specifically with insurance guidelines, depending on what care settings might be appropriate for you or a loved one with Lewy, and how to really advocate for that in today's world, which can be really tricky. Also, you'll know resources that you can use in your area to find these services, specifically for people with experience treating Lewy body. And then also kind of what to do after you or your loved one is done with therapy. That seems to be another big area that's gray of how do I continue then and stay active and stay as healthy as possible for quality of life. So this I love. So confused about insurance and knowing what you qualify, how does that go? It is a maze when I tell you, and we spend a lot of time educating people. I will tell you, this is not something that we learn in PT, OT, or speech in school. It's not something that even your doctors or neurologists usually learn, unless they are a private practice business owner where maybe they're having to navigate this themselves. So don't assume that, just because you're asking your doctor for advice or their office, unless you're really speaking with their biller, they don't know specifically to the Medicare guidelines, usually for therapy itself. So just as a quick background, and you guys will get a copy of this link after, but I want you to know kind of the differences. We use Medicare as the main one because there are so many different nuances with the other commercial insurances. But Medicare Part A, if you think about it, is anything more inpatient. Okay, so when you go to the hospital, if you're in skilled nursing rehab initially for therapy, not if you're staying there for long-term care, which then switches to out of pocket usually, or if you have long-term care insurance. If you're going to a subacute rehab after maybe a short hospitalization or an inpatient acute, palliative and hospice services are usually Medicare A, although there are some changes with that you might see some palliative care that can be under Part B. And then a lot of you that might get official home care, meaning though a comprehensive home care agency where they also offer nursing services. Okay. And that can be done in someone's home, but also if your assisted living or your memory care is considered your home full time, you can get a home care agency to come out there. And there has to be a homebound status, meaning that someone would only be leaving that setting really for doctor's appointments. It used to be doctor's appointments, church, or for any beauty, getting your hair done or nails, which we never understood under Medicare. But those are kind of, it has to be very taxing to get your loved one out if you are the main caregiver taking your loved one to a doctor's appointment. And you could get nursing, you could get therapy, social work. Now, an aide is in there. However, people think that hiring an aide or CNA would be covered under insurance sometimes. That's not the case. This aide is like a half hour, a couple times a week, just to help with self-care, maybe in the morning, or to help with showering, quick get dressed, and then they have to leave. When you need more service than that, that's where it becomes out of pocket. Or if you have long-term care policies, again, sometimes that can be covered. And that's a whole nother area. But under Medicare Part B, think of that as your traditional outpatient practice. Whether if you've ever been in your past for an orthopedic issue, same type of thing for the neurological. So you could have therapy in a clinic, in a brick and mortar. It can be in a large or small community hospital outpatient clinic, or it can be mobile therapy, which is part of what we do, that it can be in someone's home. And this other, to think, compare it to the Medicare Part A, you do not have to be homebound. And there's no nursing needs because it's only therapy. So it's only PT, OT, or speech. But for many people with Lewy, this might be easier because it can take a lot longer to get someone ready, or depending on how they sleep at night. Or I know for some of our clients, you just never know what the morning's going to be like. So coming to the house can also be helpful for the caregiver if there is one. And again, no nursing needs at all. That can be covered under telehealth services still under Medicare through the end of this year. Again, they extended it, or in person, and also can be in an assisted living or memory care, just like the Part A. The difference is they don't need nursing, or maybe there's a nurse on staff already there that's kind of helping them with whatever their needs are. They were just getting therapy. Be aware. So going to the emergency department, which happens to a lot of our clients, they may not always admit someone. I had a client a few weeks ago with Lewy who was having a change in symptoms, and we wanted them to go to get checked for a UTI, and they never admitted them, but they were there overnight. And unfortunately, there was no beds available. So that was just considered, they were there for observation while they did all of their blood work and their urine culture, but they never admitted them. So that wouldn't go under the Medicare Part A. And we'll come back to that on why it's important for you. Palliative care, there are a lot of new companies popping up that are palliative care services that you can get under Part B, which they don't have their own therapy companies connected to them usually, or they don't provide that. So if you have a therapy team that you're already working with, they would be a separate entity from the palliative company to help you. And the palliative care is really a nice leadway between the outpatient and hospice, or needing more support, but you need more support than regular outpatient might be able to provide on its own. So palliative can be a really, really great level of care for some people that are advancing more with their diagnosis. And then also Part B is any of your specialists, your doctor's appointments, your lab work, your x-rays, all that kind of stuff. And this can be really confusing, I know. And even when we explain it to people, it's still not always 100% clear because there are so many possibilities of going back and forth. Medicare Part B specifically, and many of you probably already know this, maybe some of you don't, but if you have Medicare and a secondary, that secondary is called a Medigap plan, and Medicare covers 80%, and your secondary usually picks up the other 20%. So this is important when and if you are going for therapy services, because if you have Part B and a secondary, usually your full visit will be covered. Unless you have a deductible at the beginning of the year, maybe that wasn't covered yet. And there are some Medigap plans that do have a small copay, but very rare that we see in our practice. But if you don't get a secondary plan, just to be aware that that individual is responsible for that 20% out of pocket. So it may look good to save money in the beginning, thinking because some of those secondary plans can be expensive. But if you are someone that needs ongoing therapy and multiple types of services, and this would also count, by the way, for any lab work, doctor's appointments, that 20% would be out of pocket, which can add up very quickly. You know, it could be $10 here and there, but if you're in services for quite a while, that might be more than what a monthly cost would be. So that's just something you'd want to consider. And the updated Medicare deductible for this year is $240. Oh, and sorry, I see a little typo. I spelled two wrong, but they increased the deductible because of the increase in healthcare costs this year. So that's usually what you're responsible for at the beginning of the year, unless your secondary were to pick it up or something of that sort. The bottom part is something that I think is really important. So a lot of people will say, oh, well, they come to us for therapy after maybe going to another practice. And some of you may have been in this situation where they're going to say, oh, I already met my therapy cap. Well, the cap was repealed a long, long, long time ago, years and years ago. There used to be a cap that you couldn't get therapy for more than, let's say, a certain dollar amount or a certain number of visits. There is no more cap in today's world. So what they do is they call them thresholds. Okay. So when you're getting visits and you get your EOB, your explanation of benefits of how much you've spent towards your therapy services, the first threshold is $2,300. And this isn't really something that you guys ever have to follow, to be honest. The company that you're working with should be able to tell you at any point. You do have to wait till the payments come in, till it's updated. But PT and OT share that dollar amount. Think of it as two buckets. So PT and speech, and then OT. The reason they all don't get their own bucket is because when they made this new change, they forgot to put a comma on the legal paper between PT and speech. And I can't believe that hasn't been changed yet. So if you're getting PT and speech, you're going to reach that dollar amount very, very quickly, whereas OT might spread out a little bit. Once it's reached to $3,000 for the same as above, then that's where the therapist or the company is more open to audits. Just so you guys know, that's considered the second threshold. And at that point, that's where we really need to make sure as a therapist and for billing purposes, in being ethical, that the goals are still warranted and there is skilled need for therapy. So if you're going somewhere, and we'll talk about this more, but if they tell you, oh, you used up all your visits or you reached your cap, it's really good for you to know and to advocate. And we'll tell clients to say, well, actually, that cap was gone years and years ago. And then because some of the therapists just don't know. If they're not educated by the company they're working for, therapists are not billers. We don't learn this stuff, like I said. So it's just really important to have that conversation and to know. However, in order to continue, there has to be a very true skilled need, which we will dig into a little bit deeper so that you are aware of that piece of it. And I did want to talk about this a little bit because we've had a lot of clients over the past year. They're saying now that there's more Advantage plans than regular Medicare plans right now. And so part of it, though, is simply because when people are picking their plans, they're not being fully educated on the differences. And so many of you may have a Medicare Advantage plan, you know, Aetna, United, there's a lot out there. And they might be cheaper, absolutely, on your monthly costs and expense. However, there's usually a lot more limitations with there. So we will usually tell people, and some of the companies that we work with that help, you know, during open enrollment for our clients, is that if you're really in good health and you're stable and you don't usually spend a lot on medical expenses, and if you're open to using doctors that, you know, may not be on your list of current doctors, a Medicare Advantage plan can definitely save money. However, if you have Lewy or your loved one has Lewy, health can be unpredictable in general as we age, but then throw in there other things. If someone has a fall, if they're hospitalized, if they're having to go to the emergency department, if there's other things that pop up, if you're having to get therapy, you know, yearly, thinking of things like that, or maybe seeing a specialist or go for testing, that can be more expensive. And that's where it might be cheaper to get, or more beneficial, not cheaper, sorry about that, but to get a straight Medicare plan with that secondary Medigap. So it's just something to think about. Some of our clients with the Medicare Advantage plans that we may have worked with, they'll switch at open enrollment. They didn't even realize that they switched. And then they are limited or capitated to go just to an orthopedic practice for their Lewy symptoms. And generally speaking, they have no clue about treating someone with Lewy. So they're just not getting, and no offense to them, but the best care as if they went to someone with more neuro experience. So definitely something to consider. And also, once you're in a Medicare Advantage plan, you may have to wait a while to get back to regular Medicare. So that can also be something that you just want to be aware of to advocate for yourself. So part of that we're also going to talk about the cap that we talked about, which is really a threshold. So under the Medicare guidelines, and it's a long document. There's a whole chapter on it that is very confusing and not always 100% clear. But when you first sign on for therapy, everyone is entitled to an initial evaluation. And when someone is first seen by a therapist, in order to be medically necessary, right? The goal is to make sure that there are skilled rehab goals for that person. So skilled rehab goals mean, well, I just want, if let's say someone's going on and say, oh, well, he really wants to, you know, be able to go to the gym still and lift his weights and do that kind of stuff. That really wouldn't be necessarily skilled under the Medicare guidelines if you're already going to the gym doing that. It really varies on what symptoms are going on. But if there's been a recent fall and then there's some balance issues and that person can't get out to do their normal routine, that would be a skilled goal to get them back to where they were if that's possible. So the frequency is usually anywhere between 1 to 3 times a week to start. And then slowly it will taper down until someone graduates, we call it, instead of being discharged, because usually you're going to be going back and you're with that person, but it's nice to graduate to show your progress. And in these skilled goals, your doctor gets a copy of it. They have to sign off. There has to be progress that's shown each month towards those goals. Versus there is something called skilled maintenance rehab. And skilled maintenance is especially for folks with neurological diagnoses that we see used most frequently, where let's say you reach those rehab goals, and many of you may have experienced, but once you or your loved one are discharged, quickly that person may go downhill, right? Or quickly they may not be doing what they should be doing. Now, there's a couple things. If that person's not doing it, but they're able to, and it's just more of a motivational thing, unfortunately, that does not consider it to be skilled. But the goal would be to maintain or prevent a decline in function, okay? And generally speaking, meaning that it needs the therapist who is trained and using the skills to, let's say, each week might fluctuate based on cognition, or maybe it's just not safe unless it's done by a therapist. Those would be more considered the skilled maintenance goals. A lot of doctors and social workers that I talk to, unfortunately, think that, oh, well, isn't there maintenance now so someone can just stay on forever? Unfortunately, that's not the case. So we really have to go into the Medicare guidelines for this, which I know this is very confusing, and this isn't something that you would have to remember, but it's important to know that Medicare does cover these maintenance types of rehab before someone is discharged. These are less frequent though. So we have a lot of people on that are maybe only, every 2 weeks. It might be once a month. So we're just going in to recheck, reassess, and then maybe change something around. Or we have someone that's only safe, doing certain exercises with a therapist because they have low blood pressure and we have to assess the blood pressure to make sure it's not dropping. Things like that we would be changing on the fly kind of during the treatment. And again, we still have to get the doctor to sign off and we still have to show progress. Okay. But that is something just to be aware of. I will tell you around here locally, and I'm outside of Philly, not all the practices do it. It's also really based on kind of the specialty that you go to. And some of the bigger locations, may not be as aware of it depending. So it really just varies. So again, for the skilled care, so a skilled therapist means a PT, OT, or speech therapist, okay, who went through, they have their degree. It doesn't mean that they have to have tons of certifications specific to neurological treatment, but they have to have that degree and licensure, and meaning that it would take one of us to assess the client, maybe give different cues that might be required. Some people can't follow more than one step at a time. We might need to change the way we're presenting our instructions, or training for the caregiver or care partner, right? Maybe we're really having to train a spouse or a child or a paid caregiver. But the guidelines of Medicare are very clear that if a lay person could be trained to perform whatever we're doing safely, I will say, and again, could be a paid caregiver or a relative, or here's the other scenario, under Medicare, if the patient lives alone, unfortunately, that doesn't cover Medicare for us to keep seeing a person. If a lay person can still do it, even though there is no aide or care partner in the house, the services are not considered skilled anymore, which is not our rule, unfortunately. And we say to everyone, we would love to stay in forever, but these are the guidelines. And if a therapist is still seeing someone, but yet it's not skilled, then that becomes an issue potentially for their license and with Medicare. So it does vary. Again, I know this is very confusing, and we have to have this conversation with almost every client that we see, and explain in detail the Medicare guidelines. So services can be provided. We do get a lot of this question too. If there's no skilled needs, services would be considered wellness. And that's where it would be out of pocket though, until that person goes back on Medicare, which does happen frequently, because there are changes. So, and it's not that you'd have to wait a certain number of months specifically to get back on. There's no guidelines on that. But if there was a change, let's say in status, if all of a sudden there were more falls, if there was new medication added that changed the function or cognition of someone, those are all things that we could look at to at least do the evaluation or consultation and then see if there really are skilled needs at that point in time. Again, we call them like a tune-up if someone's already been through therapy. So just like you bring your car in. And this is the other part that I wanted to just review about the emergency department, because this plays a role. We have a lot of people that go in and then it's not safe for them to go right home. And their care partner or caregiver really wants them to go for short-term rehab. Perhaps there was a fall or, a change in cognition, and there was something that the client or the patient wasn't safe, and they needed a little short bout of therapy inpatient somewhere. So to go to skilled nursing, if someone's in the emergency department, there has to be a 3-night stay in order for that to be qualified. Now, I will say we are very blessed. The neurologists that we work with in this area know the rule. So if they're trying to get that client in, they will push for their patient to be admitted to the hospital. But this is where, if you're in the emergency department and you're there or you're put into a bed, but they did not admit you, it's just more of a holding or observation, that would not count. And that has happened to quite a few of our clients. So it's just something to be aware of, that 3-day rule. Again, you're not going to remember all of this, but it's important just in advocating for you or your loved one if that were to happen. So some of the myths, and these are real questions and things that we've been told from our clients that we see. So you can, rhetorical question, but if you've had this or brought it up or been told this, okay. But some people think that they can only get therapy once a year. Okay, that's false. Or you can only get it if there was a fall or a hospital stay. That's false. We already talked about the certain number of visits. Medicare doesn't go by visits. Remember, it's a threshold with a dollar amount. And you can still go over both of those thresholds as long as there's a skilled need. Some people think if the neurologist didn't recommend it, that they don't need it. But then again, some people don't ask, especially for my newer diagnosed folks with Lewy. I would say we see that a lot. Like, well, they said like, I'm doing really good. I haven't had any falls or anything, so I don't need therapy. And then we might talk a little bit more and probe a little bit more and realize that's when they should get therapy, right? That would be really helpful to initiate some exercise and kind of education with that. Caregiver or care partner training is not covered, so that's false. Medicare will cover caregiver training and especially in a clinic or in the home. And as long as the patient is home. Now, I will say there are some new codes that Medicare came out with this year that are still a little gray. So I didn't want to cover that because I'm not 100%. We've had some changes with coverage on that, but they are looking into caregiver training, even if that caregiver does not live with the person with Lewy, that there would be some coverage. But there's some gray areas about if that has to be in person or telehealth. So just FYI, and that could be something you ask based on, who you're going to, or if you're seeing a mobile practice or something of that sort. The other thing, how many of you have been told like, oh, well, they don't do their exercises, or, oh, they weren't compliant. They didn't use the walker from the bathroom, so they had to be discharged. They don't qualify for therapy. Well, I'm sure that is very, very common. We hear that all the time. And making sure that, think of if there's memory issues or executive function or safety or anything of that with Lewy, that person just may not remember it. And that may not be a realistic goal. So whoever you're seeing for therapy should be thinking outside the box on how to make that safer. But that is actually false to say that they don't qualify because of that. And remember, we did say you can get a tune-up, yes, under Medicare. There's no set timeline. What we usually say, I would say we see most of our clients with Lewy because we have a large Parkinson's population, probably at least twice a year. And it might be the second time around is much shorter, but they need a little tune-up, or there's been a change in their walking, or in some of their self-care needs or maybe their voice. So they need a little tune-up for that. The other thing we got come January, this was especially, you go to your neurologist, they give you, oh, here's another prescription to keep going. So that's one thing. Or, oh, we got so many referrals in January because they were told by their doctors that January 1st, your threshold resets that dollar amount that we talked about. So everyone thinks that means come January 1st, even if they were discharged in December, that they can restart therapy. So that is actually false, both of those. And we have to call a lot of the doctors, especially more primary care. Most of the neurologists know now because we've educated them locally, but just because they're giving a prescription, and some of them will give many prescriptions, oh, keep going, you need therapy, you need therapy. But if there's not a new skilled need or a continuing skilled need, we can't keep doing therapy. And again, that's a Medicare guideline or the other insurances guideline if you don't have Medicare. And just because the therapy threshold resets doesn't mean you can restart. There has to be a skilled need. So, there's a lot of areas in here that you may have experienced. So I like to always include these myths in there. All right, so now we're going to move on to the rehab services for Lewy. And the considerations for therapy with Lewy, okay? So there are, and I know Julia would agree, there are many things specific to Lewy that would be a red flag for me, sending one of my clients to someone that's not skilled in the beginning to make sure that certain areas can be, assessed and tracked and making sure from a safety standpoint. So many of us know, or you may experience orthostasis. So your autonomic nervous system doesn't quite work as well sometimes. And a lot of people drop in blood pressure with or without symptoms. So there could be some lightheadedness, or someone can just pass out, which they called syncope, or they can just be getting really lightheaded. Dehydration is also a huge piece of that. And some people are on medications to increase their blood pressure, which then can make it too high. And then they're on another one to lower it. So we spend a lot of time with vitals with our clients, vitals meaning checking the blood pressure and the heart rate and all of that. There can be bowel and bladder changes. So considering what kind of exercises you're doing, or if you're going out to a clinic, is your bladder, is it hard to retain? Do you have urgency, or is there incontinence that can make it really challenging, once you're out? Is there a schedule that you're on for using the toilet, things like that? Also, your thermoregulation. Someone can be really hot or really cold. Fatigue. So the fatigue piece can affect, like, is it longer and more time to get in and out of bed in the morning, or to get dressed, or take your medications and breakfast and all that. So, and then is there daytime sleepiness or fatigue? Are you too exhausted after therapy? Is it safe during therapy if you're getting tired and maybe the balance is getting worse because of that? Or as the day goes on, a lot of people will say that function is worse at night. And unfortunately, they're not usually in therapy at that time. So we may not be able to see those scenarios. The timing of the medications can be very, very important. And a lot of the therapists might track that. And then safety in general, right? Is there a fall risk? Do you need someone with you? Is someone driving to therapy or things like that that should not be? So a lot of things as the therapist that we are really considering as the whole picture of the person. So we'll jump into a little bit about the specific therapies. And again, many of you may have already had therapy before. So for physical therapy, and OT actually covers, I didn't put them all double on both, but PT and OT, if you specialize in neuro, you're really working on a lot of the same things. But as you know, there might be slow movements or bradykinesia, rigidity, the tightness in the muscles, stiffness, which can cause pain sometimes, walking instability, which some people may have shuffling or freezing of gait, if you've heard. Is there a device that maybe can help someone walk safer? But then as as Lewy advances, sometimes then it's not safe at all to use a device. So really a PT would be the best person to assess for that. And a lot of the neuro PTs, may work with some of these companies that to trial some of the equipment with and have better input on that. Balance, falls, we talked about. I'm going to skip the one for a second. Cardiovascular endurance, if someone's becoming less mobile, is that something? Or just as we age and there's more cardiovascular issues, strength, coordination. But LSVT big is a big one, right? So, and that's PT and OT. And LSVT is the Lee Silverman voice treatment that started way back when for voice. And big are the large amplitude movements that many of you may have been through. It's covered under insurance, but it is a 4 times a week for 4-week protocol. So there is a commitment. The nice part about big, though, I always say when someone's first diagnosed with Lewy or Parkinson's, I'm usually saying this is a great foundation for you to do first. And especially if someone can remember and follow the cueing, but it is, twice a day. So if someone can't do it by themselves or there's not someone to guide them, it may not be appropriate. And also they can be done seated for a lot of our folks with low blood pressure or safety issues, or even in bed for some more of our advanced clients where you definitely need a good care partner with that piece of it. And these are just 2 of the programs. So LSVT big, and then Parkinson's Wellness Recovery is another certification that many of us neuro PTs and OTs go through. And that is, again, large amplitude movement, but there's no set protocol for numbers of days, things like that. And again, really tied to function, lots of fun, I think. These are a couple of the devices or the options. For some of you, the one on the left, you may have seen or have a U-step walker. And the U-step has a laser, like the third one that you'll see, the third picture, that shows up to give a visual cue for someone for foot placement or to take bigger steps. Now, I will say that it is covered under Medicare, but Medicare has a 5-year rule for their guideline. So if you have another regular standard walker, let's say from a hip replacement or a knee surgery or back within the past 5 years, Medicare will not pay for this. And this is much more expensive. So I think to buy them out of pocket with the laser, I want to say it's around 6 something. Medicare pays for the walker, but not the laser. The laser is $250-ish. And not everyone needs the laser because sometimes the visual input isn't accurate for someone. As we know, there's some visual changes that happen with Lewy. Sometimes the red is hard to see. If it's a really well-lit area, it doesn't show up if there's a lot of natural sunlight coming in all the time. And for outside, it doesn't really show up at all. The one in the middle, I usually don't have anyone buy it, but they do have a cane with a laser too. The cane, in my opinion, as a PT, is hard to coordinate a little bit with the steps. And then I always worry it's not going to give enough stability, but we do see the U-step used a lot. And Next Stride is a laser component that you can get that attaches onto a regular walker if you have it, or a different rollator that's not the U-step. But again, they're expensive. I want to say last time I spoke with them, it was about $499. So you would really want to try this stuff out to make sure it works. And many of them have like a 30-day trial thing to make sure that it would be appropriate. But your PT would really be your best bet. We don't want people going out and buying all this stuff and trying it and not knowing if it's going to be the right one. And these are just some of the other, that's the rollator on the left, which has a seat. The difference between this and the U-step is, though, this one goes a lot faster because of the 4 wheels. The U-step has a U-shaped and it's a little bit heavier and it seems to make the turns better. I've had some of these tip on people. The one in the middle, I hardly ever use. They tip, they're hard for turns. People can get their feet stuck on all of these walkers, so that's something else to consider. And then the tripod walker, which can be a little tighter for some people who maybe live in an apartment or more narrow area, not a lot of space around things. But again, if you're going somewhere for therapy or they're coming to you, they may have trial stuff that you can see and play around with first to help you make that decision. The other one is the up walker, which I have a lot of people ask me about. And it has the upper extremity supports that you can put your arms on to help stand more upright. But I will tell you, if someone's really hunched over, they're still hunched on this. So someone needs pretty good trunk support. Otherwise, they're walking in a half flexed position. And these can be very bulky in the house and hard to see over the front of the walker. So again, definite considerations. Insurance does not cover this type of walker. At least they didn't as of last year when we were trying to look into that for a client. And then I'm just going to share with you, these are some treatments that we worked in the clinic, and you'll see the first two is a device called Balance Matters, and it's an auditory feedback for someone who was taking smaller steps and shuffling. Okay, so I'm going to show this first. This is at our clinic with our PT Barry.
So we're going to do that weight shift. So you're going to shift forward, click. Good. Swing those arms forward and back.
So you see that click and you hear it there.
Bigger. Left click, right click. Shift your weight. 1.
Yep.
2. 3.
And we're really trying to incorporate the voice with it. This is someone that was newly diagnosed, still very active, drove himself to the clinic, wasn't being seen at home. This is someone who was needing more support. His wife brings him in. He uses a U-step walker. And we were working more on side to side movement because his house is really tight and he has to kind of sidestep to get in at night to where his bed and his night side table are. So working a little bit this, and then this gentleman primarily uses the wheelchair for most of the day. But I want to show you guys how, you know, we can still work on things because he falls a lot. So we wanted to work on kneeling, but he couldn't get down on the floor yet. So I'll just show you a little bit and using a cue to help him move bigger. Oh, sorry, wrong person.
Spring up and send your hips to the wall in front of you. Try it again. Even bigger. Send those hips towards the blue wall. Better.
There you go. And you could see how he moved bigger, but he can never do this at home with his wife. And, you know, we'll do a few of these and then he's pretty wiped out. Wait a minute here. Okay. So then we go to occupational therapy. And occupational therapy, again, all the other stuff we talked about with balance and endurance and all of that stuff that someone can work on. The other part with OT specifically is activities of daily living. So we do see quite a few number of clients, and you guys might see, you know, it gets harder in the morning to get ready and get dressed, or even in the bathroom, you know, when we see some people at home, there's so much stuff all over the sink. Someone may have trouble even figuring out the toothbrush and getting that, or brushing their hair, anything. So really kind of making things as simple as possible, especially if there are some vision issues and just overstimulation, working on vision and really figuring out how to make things easier to see or to process, especially at home and with exiting the home, with cognition, maybe working on some problem solving, attention. Again, that attention can be if there's too much going on or too much clutter, or the TV's on, the phone's ringing, and we have a loved one trying to tell that person something. It's just way too much sometimes, you know, working on overall strength, fine motor coordination, right? Like use of the hands can get harder dressing, for buttons, for writing, if that's the case. So even for using utensils or feeding, right? Cutting food. So things like that can be worked on with OT. Again, the LSVT Big program. And in some cases, depending on the company that you might be getting therapy from, that 4-day-a-week protocol, they might split it between PT and OT so that you're getting the best of both worlds, which I love. So then you're working on some OT goals and PT goals. Skills to Care, which we'll go over a little bit more, which is a caregiver training program covered under Medicare that requires a very specific certification and is not as common to find. And then right? So OT, a lot of times our OTs are working just on a sleep hygiene, and you might wonder, well, what is that? Maybe you have someone that's up a lot during the night, or they're getting up, going in the kitchen, or maybe there's more hallucinations at night. But if someone's not sleeping great at night, the day is going to be a nightmare, right? And trying to get these other appointments in, or just even being on some kind of a routine because that person's never catching up. Or maybe it's more of an incontinence or a urine issue at night that can be worked on, thinking outside of the box with how OT can help with that. So a lot of people think occupational therapy is just your occupation, which part of what you do for a living, but also all the things that make you you, that you have to do every day at home or in the community. Skills to Care. So this program is amazing. It's evidence-based. It came out from Thomas Jefferson University, which is in Philly. And it has to be provided by a certified OT. And it's specific to caregivers or care partners of someone with a dementia diagnosis in general. It can be Alzheimer's, it can be Lewy. So lots of different kinds of dementia, but we see it a lot with our Skills to Care for Lewy. And in order to qualify under insurance, the person with Lewy or dementia has to have at least one of the following. So a decline in function, fall risk, safety, maybe resistance to care, which could be bathing or dressing, maybe some self-destructive behaviors that you might see that are not safe. Any challenging behaviors at all. If someone's agitated, if they're repeating, if they're verbalizing the same thing over and over, memory, shadowing their loved one, following them around, hallucinations, incontinence, perseverating on things. And then the other part is like, is there a schedule? Is there boredom or apathy, lack of interest in anything that they used to be? Activity. So that can be something that OT can really help kind of put together a schedule, something of that sort. And then for the caregiver, they have to at least have one. So being overwhelmed and burdened. So a lot of people are overwhelmed. So that's pretty much an automatic that most of our caregivers have. Maybe needing some more education for dementia. You know, it can be a caregiver that's paid or a family member, but there has to be one primary caregiver that is trained in this. And again, and you'll see after in the links, there is a website that you can find a Skills to Care provider near you. These sessions are not usually as frequent as 2 or 3 times a week. It usually might just be once a week, because then you're learning some new strategies that then you're going to carry out and follow up with your therapist. And it can be delivered virtually or in person. So I just want to show you an example. The other thing that might be worked on is falling. So we were very creative, and this guy loved doing it for the video. So falling backwards, you're going to tuck your chin in, arms up. Good. Get those legs up. There you go. Good. Getting up was not as easy, but he falls quite often, like probably 4 or 5 times a week. And so we work a lot on the floor and moving his legs. And then we work on turns, because turns are really, really hard for a lot of people. And that's where falling backwards, that's where a lot of the balance stuff can happen. And that's usually how this when you're there, but now you have to unlock or open the door. No, and if you start walking backwards, that's a higher risk of falling, right? So if you're going to back up, take those big power steps back, like when you're bowing to the queen. And that's part of the LSVT. That's what we use for LSVT. Okay. And then when you go to open the door, you want to be at a diagonal to it.
Yeah, I am.
Okay. So that you don't have to step back. There you go. Perfect. Okay. And then you see the tape on the floor. We put tape there. Did you power up?
No,
All right.
I don't think
Big steps over that tape, right?
Yeah, I can think of there's so many things with this.
I know. So there's so many things. And unfortunately, in this situation, his wife still works full time. So she's not present for a lot of the sessions, which in this case, unfortunately, I had to end up discharging him because there was no one to train, even though she was home working in the other room. She was too overwhelmed at this point. So we finally just started up again because now they hired an aide. And we had to speak with the neurologist and let everyone know where we were, because you can only make so many recommendations. And if there's not follow through, unfortunately, it's really hard to keep justifying why we're going in certain situations. Yep. Sorry. This is where the, here we go. Okay. So speech therapy. Speech therapy, a lot of people have issues with swallowing or dysphagia. Speech in general, the volume you heard in that video, his voice was really hard to understand. It's very low. Cognition with executive function, organization, sometimes insight into their risk of falling. LSVT loud, which is working on the voice component, just like big is the big movements. And Speak Out, which is another great program through the Parkinson's Voice Project. And then the Speak Out Therapy Group, which is usually a free maintenance group after they graduate. So Loud and Speak Out are under insurance. Loud is, again, 4 times a week, just like Big for 4 weeks. Speak Out officially is 3 times a week for 45 minutes. But it really just depends on the individual. They are not as strict with the protocol, but there is homework, there's a book with it. And also the Speak Out group is usually once a week, and that can be virtual or in person, depending on where you are. So just to give an example for speech, this is one of the Speak Out groups that we were running. So some of you may be sick of that if you've been through speech therapy, but that's part of the beginning. And then these links will all be on there, but these are how to find the therapists who specialize in this area. And I believe there's a few more on the links, but also you can ask your movement disorder specialist or neurologist if they know, because they might be referring to therapy a lot. If you do have a practice that you're thinking of going to, or where you have to go to because it makes it easier for you, ask them when you call their office, like, do you see a good amount of people with Lewy or Parkinson's? So there's not a lot out there specific for Lewy exercise and therapy, but if you follow the Parkinson's providers, there's so much Lewy with that you're going to find someone that has that specialty and that background. Or if you're in a local support group, that can help too. And then when you're done therapy, you might be wondering, oh my God, well, what am I going to do? So again, this is all in there. The Parkinson's Foundation has really great recommendations. So we follow this with our clients with Lewy, and they talk about the guidelines of what they're looking for. But the golden standard is 150 minutes of exercise a week, which we know can be really hard, especially if you're having to do it on your own, or if you're a care partner, that can be really challenging. But there are wellness options out there after therapy. So considering, can it be done by yourself, or is it better in a group? Can you stand, or do you need to sit for safety? Can you do virtual and get on Zoom or some of the other, or watch a pre-recorded video, or is it better in person? Again, do I need help? And are there other medical conditions to consider, like arthritis or vision, things that might happen just from aging in general? Back issues we see a lot. And these are just examples of someone that does it at home. So this is my guy, Bob, who loves the video too. And, he's following the instructor on the left on a Zoom class in his basement. This was a shadow boxing class. And he follows it really, really well. He's such a good student. And then again, thinking about, can someone do it? Listen how loud this class is. Right? So this is a younger group mixed with Parkinson's and Lewy body, and not younger, I shouldn't say, earlier diagnosed. So I think everyone in the class is over 60, but newly or younger on the diagnosis stage of Parkinson's and Lewy. So there's attention issues that are very mild at this point. Otherwise, they wouldn't be safe and appropriate for this class, right? And then again, thinking about the group classes, I'm a big stickler on, if you're doing a big group class like that, you really need to make sure that there is a skilled professional on board, meaning a therapist, because if you're going to a class that has a lot of risk of falling or safety issues, if it's not someone that's skilled on looking at the blood pressure, being aware of changes in gait, of freezing of gait, of the vision issues, you can really be putting yourself at risk. So I am very, very strong on that. Versus a personal trainer running a group setting. Now, I will say there are some personal trainers that we work with who do one-on-one stuff with some of our clients when they're not with us. And maybe that's more, at home, they might be doing some stretching and other things that are safer, but we talk to them, we make sure we're on the same page. And there are some people that have a lot of specialty training or maybe worked under a therapy practice or a neurological setting or a rehab as an aid, something like that. But really being aware of who is the credentials of who's teaching those classes. And again, these are just ideas, but then there's a lot of cardio that can be done too. And the best advice is really, it has to be something that you like, right? You want to get something out of it. That's the most important. Otherwise, you're not going to do it. And whoever's telling that person with Lewy to do it is going to be more of a nag. And then there's going to be tension. We see it all the time. So we have to meet in the middle. But your skilled therapist, PT usually in the beginning, can help kind of set up this program for you so that when you graduate, you know what the plan is until you come back for that tune-up. And with this, so again, who runs a group matters, and classes are not one size fits all, but a group, the benefit is there's a lot of social piece in there, right? And you can have fun and camaraderie. So versus maybe someone who's stuck at home and not socializing or using their voice or things like that. But again, it has to be a good fit. And there are seated classes depending and standing classes. I will say with Rocksteady Boxing, and that's on the links, you would want to make sure not all classes are run by therapists. So if you have Lewy, you need to be really, really aware of that piece of it. And there is a link to see location-wise what's near you. And there are seated virtual Rocksteady and standing. That's just one of the groups that we run. So I know more about that specifically. And it's not all boxing. I'd say it's 25% moving the arms. The rest is your voice and your posture and some cognition and quick thinking, things like that. This is just one that a lot of our clients have bought over the past year, and they've given us really good feedback, the QB. So it's something that can be done at home from a wheelchair, from a chair, sitting there watching TV. And it's almost like a mini little elliptical machine. So that's one thing that you can use. And again, you'll have the link. And then, the the LBDA, the Lewy Body Dementia Association, has great resources. They have their Lewy line. They can guide you on local resources that are available there. And again, there's just so much out there. I know it's a lot of information to cover in a short time. And that's it. We got through it. So I'm going to stop sharing.
And unmuted me. Hello. How are you? Nice job. Thank you so much for the incredible presentation.
Yeah, it's a lot of information.
Absolutely. I think that this audience at this point is used to drinking from a fire hose a lot. There's so much to talk about. And we had some great questions that came up. And one of them just now in the chat, I think is really important for all three disciplines, but this person asked it specific to speech therapy. So let me open up and make sure that I'm not misquoting anyone. So when should, and I think they say speech therapy be started for prevention or treatment of dysphagia? And I think within that, we can talk about when should therapy begin in general. You
As soon as
touched
you're
on that, but
diagnosed, as soon as you're diagnosed.
absolutely agreed.
I cannot say that strongly enough, because insurance will cover that with the diagnosis, and there's goals for education. So maybe physically or swallowing or voice, yes, maybe you are fine when the neurologist sees you, and usually you're looking really good. You get dressed up for your doctor's appointments, right? So they're like, oh, they're doing fine. But you can still say, hey, listen, we would really like a prescription. That's what I say. We would like a prescription for PT, OT, and speech to at least get a baseline evaluation. We want to learn as much as we can on what we can be doing now. And maybe it's not a long course of care. Maybe you're only getting a few sessions, but the sooner you can start and have that foundation, that I call it, is so much better. I mean, we see some people that were diagnosed 10 years ago and just getting therapy, with certain diagnoses, that if they would have been doing more before, it wouldn't have been so drastic of a change for them or their loved one.
Absolutely agreed. And one of our head neurologists at Penn always sent them to us at diagnosis. And I think a lot of it, you guys, I've talked a little bit about what I call the Little House on the Prairie complex, where we feel like the doctor's going to answer all of our questions and give us all of the resources we need. And a lot of times that more happens in therapy. We're really going to a lot of times look at, do you need a support group or an exercise group, or what education can we give you, or pamphlets or brochures. So I think that it's really important to get your whole team involved from the beginning. That can be social work, maybe palliative care, depending on the setting you're in. So well said. All right. I think this was an interesting question too. So we got, did the Medicare guidelines differ if someone is in a skilled nursing facility? And so this individual says that they're having trouble getting their client added services in a skilled nursing facility, and they're being told it's because there are different guidelines and that they're more restrictive.
They are. Medicare A is definitely more restrictive than Medicare Part B, unfortunately. But depending on the setting, some of the skilled nursing facilities, if they're in the long-term care side of things already, can be covered under Medicare B. Medicare A would be more of a skilled acute need. So your loved one went out to the hospital, they had a UTI, or maybe they had pneumonia. They came back, that would qualify them because they're going to need a nurse, they're going to need therapy under Part A. Some places will have the therapy team that's in there provide some services, but they are much stricter. And unfortunately, it's just, they're not specialized. Most therapists, and forgive me for saying this, and Julie, but most therapists that are working in skilled facilities, because the Medicare doesn't even allow to do like a big program for 4 times a week or things like that, there may not be as much specialization, and not that they don't want it, or maybe reaching out and connecting with other local therapists that have more expertise. But it is much, much harder. And if there's not a new thing that qualifies them under Medicare Part A to get therapy, but a lot of these places do have restorative services done through maybe some of the CNAs, where there's daily stretching or walking, or depending on what your loved one's level of function is. We have had some clients in skilled facilities get approval to be taken to our practice for outpatient therapy. So if you work or find a place near you that specializes, and they don't have staff that do, sometimes, but you have to really, I think it took like over 6 weeks to get the approval. My office manager is very used to doing this, but it's hard. It's a lot of work.
Yeah, it sounds like it takes a lot of tenacity.
Yeah, yeah, and it can be exhausting. But that's where sometimes we will connect some people in the community with like a geriatric or senior care manager to kind of help with that advocacy too.
Absolutely, absolutely. So I have a question here that I thought was really nice, and I think there's probably varying answers, but this gentleman asked, are the classes, these exercise classes you were talking about, for both the care partner and the receiver?
That's a great question. So it depends on where you go. So of a lot of the classes, if there is someone with Lewy and there are cognitive issues or more safety issues and mobility, then a lot of them will have the care partner also, because you might be taking your loved one there anyway, right? And if you're going to be there, so a lot of times, and then it's almost like a little built-in support for the care partners, but it really varies. There's a lot of places that don't too. So I think that would be a unique situation that you'd have to call and find out. I know in the Rocksteady world, they call it the corner person. Just like someone would have a corner man in the boxing arena. And that is someone that helps them maybe with the exercises, because in a group setting, even if it's run by myself or a therapist, another therapist, there's no way we can give one-on-one to every person that's in a group. And those groups should be smaller in size to make it, safe and not too overstimulating. But so a lot of the care partners are part of it. But again, it really depends on the type of class. If it's a community class or, obviously if it's virtual, that's a different story because anyone can participate, but you would have to double check.
Excellent. And so with that too, then how do you think someone can best find a safe exercise group? I think there's a lot of exercise groups out there. We hear sometimes about falls or injuries. So what would you recommend to someone so they can find one that's really safe for them?
And it's really hard because I know there's people all over here, right? So I know very local to us, we're very blessed because we have so many providers. But depending on where you live, I mean, the first part would be, and you'll see in the links where you can find local providers and groups through the Rocksteady specifically is for Parkinson's and Lewy. So that might be a good foundation to start, but depending on where you live, it may not be a therapist that runs it. So I can't guarantee to the safety of that piece of it, or not that the safety, but knowing the therapy piece, the clinical side, right? I do think that it's very helpful wherever you go that person who's running the class would do like a baseline assessment on you. And a lot of times you can get that covered under insurance if you're a therapist, because you're doing a PT or an OT evaluation to see, there might be other needs. First, you may not be ready for a class yet. Maybe you need a little tune up, endurance wise. So I would say, asking who's running the class, finding out what that looks like. There's so many out there though, that how to find a specific, I don't know that answer. And I'm not sure, Julia, if I don't know of any resource base that has every class that's out there, but going through like a big neurological center or a big hospital system where, especially if you have movement disorder specialists in your area, which I know we are blessed and that's not the case throughout the country, but that can be really helpful because maybe they work with some of the local providers or the local hospital groups, and there's places that get grants and things like that. So I can't think of anything else.
Yeah. I think lean on your therapist. A lot of times your therapist in your area is going to know the classes that are better. Don't hesitate to ask to observe a class and watch and see what you think. I just think it's really, really important to note, you guys, there's a lot of classes popping up for Parkinson's. There's a lot of Rocksteady boxing classes around the country. Unfortunately, in the United States, we don't have anything that licenses an exercise professional, right? And that was my background. So I started out as my background was in exercise science. So they might have a certification, but a lot of times they don't have any clinical training. And that certification could have been taking a quick class online. Maybe they have no background in any type of exercise or clinical practice. So it's really buyer beware. It actually, to me, is a little bit scary because I think we require more licensing and training and certification for plumbers or for people who do your hair than for people who lead exercise. And it's really unfair because you could have someone who's very expert, has extensive certification, extensive training, all the way to someone who literally took a course online and got a certification. So I think just really be very careful. You can always reach out to our support line too, and we will try to find out an answer if we can. But I think to lean on your therapist. But this is something we're starting to advocate more for exercise here at LBDA and getting people involved. But we want to make sure that you're really being safe and being aware of that piece. So thank you, Jen. And then let's see, I think we've got another question that popped up here too. Oh, so a couple here that are very similar. So finding exercises to follow online. So something that they could do on the computer. Do you have any resources that you recommend or how they could maybe find something that would work for them in a virtual format?
Yeah, so I mean, generally speaking, and you probably know a little bit more even about this, but like I know we've recommended to some folks, like the Parkinson's Foundation has their Fitness Fridays, is it, or something on Friday? They have some fitness classes that they offer. I know through the Power Gym, they are running they have like virtual memberships that you can do. I mean, I would say if you find a Parkinson's based class, that's probably the best geared at this point. But as far as the resources specifically, I just usually guide them to either the Parkinson's Foundation, or if I know that there's local providers that do virtual classes, I'll give that specifically. So it might be asking for your therapist to let you know if you have a therapist. I don't know. I know. So PWR is the Parkinson's Wellness Recovery with Becky Farley. And that's a link on there, but they really have a great program, and there's virtual, but I know there's also free ones out there. I just can't attest to that. There's a lot of YouTube channels. You'll see everything when you type it in. So it makes it a little bit trickier, but I wouldn't say there's any specific resource that I have.
Yeah. And I think too, you guys, we did a webinar last year with the folks from Dance for PD. Don't forget about that resource. They do a lot of chair-based work too. And she mentioned Power having the online. If you've gone through the LSVT big program, and LSVT Loud with a certified trainer, there is a virtual option for doing what we call Big for Life, which is like a group class. So, but you have to have completed the course of therapy before you can participate. And so,
yeah.
And any last words? Oh, go ahead.
I was just gonna say, and the Parkinson's Wellness Recovery has a free session every morning on their Facebook page.
Nice.
And a lot of people do that. Yeah.
That's excellent. I think Dance for PD does something similar. That's awesome.
Yeah.
Yeah. So a lot of times if you hit it right, I know Dance for PD and I'm sure Power, not all of their classes are free, but they a lot of times will offer like one a week or one a month or something. So check out those sites. That's excellent. Thank you. All right, you guys, I think we're out of time. Did you want to offer anything else before you part? You did such a great job.
Oh,
Thank you so much.
I would just say, like, don't be scared to advocate, and you're your best, person to do that, right? No one else is going to do it for you. So even though your doctors may not be pushing or someone else, it's definitely something that you can advocate for, and to really live your best life, and for both a care partner, a caregiver, and the person with Lewy. There's so much that you can do. And the worst thing would be to just sit too much and to not get up and be active and to really use your mind. And, but you can definitely push for that therapy evaluation, and the sooner the better. The more you can learn and empower yourself, the better. That's just, I tell everyone that. Yeah.
Well said. Thank you so much. So with that, you guys, we're going to wrap up. We're out of time. We went a little over, but I could have gone on all day, as you know.
Sorry.
No, I can talk to you all day long. So on behalf of the LBDA, I'd like to thank you all for your time and attention. And thank you, Dr. Jennifer Brown, for empowering us all with this information and resources. As a reminder, you're going to receive an email in about a week with a link for the recording of today's presentation and the resources and links, some of them that were mentioned in today's webinar. We invite you to check out our events calendar frequently at the bottom of the home page on our website for details and registration for upcoming events. And mark your calendars for our next webinar on Tuesday, May 7th at 2:00 p.m. Eastern for Coping with Ambiguous Loss and LBD, featuring a conversation with another one of our locals, Jen Lance Wilson.
Oh, he's wonderful,
Yeah.
wonderful.
Absolutely. From Thomas Jefferson University is going to facilitate a conversation with members of the LBD community. So please take a moment to complete that survey that's going to launch at the end of the webinar to inform our content. And we hope to see you all again soon. Thank you so much for joining us. And thank you again, Dr. Brown.
Yeah, thank you so much, everyone.
Bye.